I've been asked to talk about the cancer journey in relation to hospice and palliative care. I mean, we all know what that cancer journey involves for so many people today as this epidemic continues to increase. Obviously, at the beginning of the journey, there are signs or symptoms for which they often go to you as practitioners in the community. And obviously there are investigations towards diagnosis. The diagnosis is made and then treatment begins. Now for these patients, obviously anxiety and suffering are certainly there. Great anxiety. What is going to happen to me? How am I going to cope with the treatment? What does that mean in terms of my life and my work and so on, and my family? But at the beginning of the journey, there's always hope that everything will go well. In other words, that their cancer can be treated. But if there's a recurrence, if the treatment hasn't gone well, what happens then? Obviously there are signs and symptoms of the recurrence. This may be pain, it may be a mass, it may be lymph node occurred, and so on. And again, there are investigations to try and sort out exactly how extensive the disease is now. There's more treatment. And if unsuccessful, we go into a whole new role. Now you often have new symptoms, symptoms that are more typical of the patient with advanced disease. Anorexia and weight loss. For many patients this becomes a real problem, and becomes a real problem for the families. You know, he won't eat, and if he doesn't eat he'll die, and so on. Certainly one of the things that bothers people far more than pain is progressive fatigue, progressive lethargy, progressive weakness. This alters the way they can live their life. There may or may not be symptoms such as pain, breathlessness, constipation, fungating wounds, bleeding. I want to make the point, and I'm sure Edmund will in the next talk, I wanted to make the point that unlike the way most people think, including medical practitioners, only about 2/3 of patients with pain, with cancer, will actually have significant pain. I think the assumption on the part of most people is if you get cancer, it's progressive, you're going to die in agony. This is not true. About 2/3 of people have significant pain. The others don't, but they may have other symptoms that are very troublesome, such as shortness of breath or fungating wounds. I've also put constipation there because I think we underrate the distress that's caused by this symptom. Most of the patients I see in the palliative care work I do in Singapore, most of the patients who are first referred to me are very constipated, giving them a lot of symptoms, a lot of concern, and it also takes some effort to actually sort that out. The most common cause of abdominal pain in the patients I see with advanced cancer is actually constipation. They have colic, and because they have advanced cancer, they assume it's going to be because of the cancer itself, whereas in fact it's not. Fungating wounds I've mentioned, because it still amazes me that people come with fungating wounds that are extremely offensive, extremely smelly, which make the patient quite socially isolated. And yet people are not aware that metronidazole, crushed up, the tablets crushed up and put on the wound will actually deal with this smell. Very simple, but very, very often not understood. But of course, the other part of having a recurrent cancer is this whole issue of psychosocial distress. It's at the point of recurrence that people are truly encounter the reality of mortality. Even when they're first diagnosed, even though they might think, oh, I hope I'm going to get better, I hope I'm not going to die. When the recurrence occurs, this whole issue of the meaning of life, what is it all about? Why happening to me is now arising in their mind. There's a whole change in perspective. They look at life differently. There are identities no longer related to work. Now, obviously not everyone's identity is related to work, but I think for all of us in the room, it's very much related to our work. Suddenly, if you have cancer, if it's recurred after treatment, suddenly work looks quite different. You're probably not going to be able to work again. Your whole perspective about how you view yourself is suddenly changed. You've become a different person, no longer belonging to the same group of people. The other change in perspective is about the body itself. Again, our body, we identify with our body. It's the shell of ourself. And suddenly, if you become disfigured by your surgery, if you're disfigured by a fungating wound, if you start to lose a lot of weight and you no longer look the same, if you've lost your hair with chemotherapy, suddenly your identity, your sense of self is transformed and becomes a great loss for these people. The questions that arise: why is this happening to me? What is the cause of this? And very often our patient's sense of causality is very different from ours. We might think, well, you've got lung cancer because you smoked. But maybe that's not how the patient views it at all. Maybe they have quite other views. Maybe they think, I was just so stressed at work, that's why I got this cancer. Maybe I should have stopped work before. Maybe I should have changed my job. They're asking, what's going to happen to me? What's going to happen if I can't earn the money to support my family? How are we going to pay off the mortgage? And so on. What's going to happen to me in terms of the symptoms? Everyone who's got cancer, in my experience, thinks they're going to have very bad pain. It's one of the hidden questions, the elephant in the room. They often don't ask about it, but it underlies a lot of what they're implying or thinking. We need to say to them, are you worrying about pain? And they will usually say, yes, with some relief. They start asking questions about the meaning of their life. What has it all been about? It's all come so soon. There are things that I haven't finished, things that I never did, things I did wrong. I wish I could correct some of the mistakes I've made. They're starting to ask questions about relationships. Which are the relationships that really matter? Some of the relationships that they actually were continuing before because they were important for work or for some social reason suddenly become much less significant. Those people have dropped away, and suddenly they realise who the real people, the important people, the people who will not abandon them, the people who will stay with them through this journey now become important. And of course there are emotions, sometimes shame. Things about our body often make us feel shameful when we don't look right or we've got something that's socially offensive like a wound and so on. Guilt. Why didn't I do something differently? Why didn't I stop smoking? And so on. Blame. Why didn't my GP pick it up sooner? Why didn't he examine me properly when I said that I had bleeding and he said it was just piles? And so on. And of course there's fear. Fear not only of the process of dying, but fear also of what death actually means, the extinguishing of the self as we know it. I want to say at this point, I think that many people still think that Elizabeth Kubler-Ross's stages are what patients go through. I think you all know, the sort of denial and so on, through to acceptance. This is no longer seen as one way of explaining what happens to these patients. Instead, we would say that Elizabeth Kubler-Ross did a wonderful job of actually making people aware of the need to actually consider these issues. But those emotions she described are not a progressive moving from one stage of a denial through progressively to acceptance. Instead, they describe emotional states of patients at any particular time. And so you may have some denial and some bargaining at the same time. It's not about a progression. And we're not there to try and help people to come to acceptance of their own death.